Thank you for tuning in to our take of the Milwaukee Regional Health System. I'm Amber Hill, and I had the pleasure of working with Nia Passman, Casey Darling, and Jeff Dreer. The case of the Milwaukee Regional Health System highlights the complexities of the revenue cycle management in healthcare organizations. Revenue cycle management involves the processes of charging patients for services, billing insurance providers, and collecting payments. One key aspect of this case is the difference between charge master prices and the actual reimbursement rates for different payers. Within MRHS, the study points to the difficulties of steering the revenue cycles in both hospital and clinical premises. These are often the case of differing operational processes, compliant requirements, and payment methodologies. The naming of Andrew May as the VP of the Revenue Management indicates a strategic initiative to cope with these challenges.
So we first looked at expanding the metrics for the revenue cycle. These metrics were selected based on their relevance to performance improvement, alignment with industry standards, and the impact of financial outcomes. So the overall metric added was the percentage of accounts of receivable greater than 90 days, which tracks the portion of receivables unpaid for over 90 days, which is an indicator of collection delays. For the defect metrics, the following were chosen to be added. These defect metrics were chosen because they target high impact areas that contribute delays, errors, or lost revenue. So first, the scheduling metric we added was the insurance verification rate. This is the percentage of scheduled appointments for which insurance coverage has been verified prior to the date of service. For the registration metric, we added the registration quality score, which measures the accuracy and completeness of registration data. For case management, we added the pre-authorization denial rate. This is the percentage of claims denied due to the missing pre-authorization. And the metric for clinical charge processing metric that we added was the late charge percentage, which measures the amount of charges entered after the billing deadline. Medical records metric that was expanded was days in total discharge, not final billed, and this measures the average number of days from discharge to final billing. The billing metric expanded was clean claim rate, which measures the amount of claims paid on the first submission without errors. The payment posting metric expanded was percentage of payments posted electronically, which measures the portion of payments posted digitally. And these metrics were selected over other available options because they represent the most direct, measurable, and actionable areas of weakness within each function. And importantly, they offer the greatest potential for improvement when compared to the national benchmark standards.
Though this slide contains a lot of information, please do not fear. I tried to color code things to make this slide as accessible as possible. So the intent of this slide is to compare the national benchmark values with our hospital, Milwaukee Regional Health System's actual metrics. The variance column circled in purple highlights the comparison and more blatantly shows where our hospital succeeds, where we meet expectations, and where we fall short. So as we can see, though, we have some areas where we are statistically above or very near benchmarks, such as the percent of medical necessity write-offs. There are also many areas in which our hospital's values reflect negative variances. So I've highlighted anything below a -4% variance for analysis. And highlighted in orange figures, though they show high variance, are areas which I'd like more information and data before making suggestions or recommendations. Specifically, is our low late charge rate due to us not charging for late fees, or are our hospital's patients especially timely? And though percent of payments posted electronically is supposed to help with efficiency, is this a negative metric that's detrimental to our clinics since they are succeeding in getting payments? It's just something for us to gather more information about before making recommendations. So not all negative high variances are something that can be addressed or that should be addressed based off the current workings of the hospital. So the main focus for both the recommendations and to point out the weaknesses of Milwaukee Regional Health System are highlighted in red. The benchmarks or goalposts are highlighted in green. Together, by looking at the variance in the purple column, we can see the areas where Milwaukee Regional Health System has multiple areas of improvement. So the first of which is that accounts receivable greater than 90 days, and that is at the negative 8.10%. The secondary one there is the insurance verification rate at negative 4.7%. The third of which is the point of service collection rate, also at negative 4.7%. The registration quality score at negative 7.10%, and the clean claim rate at negative 4.4%. So ultimately, I put stars next to each of those categories where improvements can be made. And of these, we have the percent of accounts receivable greater than 90 days, scheduling, registration, and billing. These are all areas that we want to audit and look into recommendations for. So now we can talk about those recommendations. So we can address some of these benchmarking categories and the categories that are being addressed first by department. So for this revenue cycle and the improvement recommendations, first for the scheduling department, we would encourage them to emphasize that insurance verification process in the scheduling department's workflow by making sure there's designated things, people are trained for it. This can be something that they would hope to educationally catch and via the procedures try to emphasize. Secondly, with registration, we want to optimize the collection processes. And so it's not just a question someone denies and it moves forward. We want to offer pre-registration. We want to make sure that we have different collection methods, flexible payment options, flexible payment plans. And if we're able to internally audit and just optimize this collection processes, I do think that that number would be able to be raised significantly. And it's the same with both registration and billing. There needs to be retraining there on correct collection and claim procedures to make sure that clean claims are being sent off and that people understand that each of the actions that are being taken in their workflow does have long-lasting consequences. So after looking at those departments and investigating the department workflows, the other two issues I wanted to address are the delays. We want to prioritize the account receivable completion and better communication regarding who is assigned to the different accounts and who's assigned to the timeliness of them. So it's trying to see where in the workflow these timelines aren't being met and trying to prioritize, possibly by incentivizing the account revenue completion in advance would be something that could be beneficial for this. And starred is the last one. Communication with these departments. So inquiring about each of the departments in this workflow, what their needs are. If there's staffing issues that are inhibiting these numbers from going up because there's too many people or there's not enough people for too many accounts, that's something that we can be addressed more directly. Understanding the technical hardships or other things that are going on, speaking to that department, inquiring about that department's needs is a recommendation that would help us with every other facet to make sure that any actions that we do take are actually beneficial.
So as Nia reviewed, we're having trouble having our accounts paid. Next step we're going to look at is our stakeholders and why these are possible issues within our system. So we'll start with our stakeholders, our providers, our insurers, our patients, and our society as a whole, or surrounding community. For our providers, they face a wide different payment system, which is based solely on who is paying. For example, Medicaid could pay 10 to 15% for a charge, while commercial insurers pay 50 to 60% for the exact same operation. Efficiency-wise, providers must navigate multiple billing rules, denial rates, and collection rates, which increase administrative overhead costs. And then these incentives are often misleading. For our insurers, commercial insurers effectively subsidize public payers, and self-payer patients pay higher rates. These inefficiencies, complexity of reimbursement denial rates and collection rates, variable coverage, and all create inefficiencies for the derivatives, which drives up premiums. Patients often have no transparency around the costs beforehand. Patients must coordinate care across imaging centers, hospitals, rehabs, and various departments before understanding the true nature of their billing. Poor coordination, especially in post-acute phases, can lead to readmissions, duplications of service, and substantial outcomes. From a societal standpoint, taxpayers are funding Medicaid and Medicare, which reimburse low cost, leading to under-resourced hospitals and valuable communities. High administrative costs, billing disruptions, and redundant care are all waste that society has to deal with. We're going to look at the data next. And on here, you can see this is kind of a summary of what we were just discussing. This is percent charges for each procedure, both the MRI and the joint replacement. Where Medicare would average reimbursement at around 10.7% for an MRI and 34% for joint replacement. They're fair, but they're often below the cost of the actual procedures. Same for Medicaid, well below, and they create risk for hospitals who are trying to pay their bills. Commercial insurances typically reimburse the highest, but they also subsidize across their systems. And then you have your self-payers. These individuals typically pay the least amount, but are struggling to pay their bills already. So these counts go delinquent most often. We're going to look at procedural insights. So we were given two procedures, the knee, MRI of the knee, and then a joint replacement. Taking away the charge master price of what it would cost, typically is for an MRI is $2,800, but the average reimbursement is only $717, roughly 25.6%. And you can see here for joint replacement, for the average joint replacement is $50,000. We're reimbursing just over 18 grand at a roughly 38% or 37%. Right, so to take away, providers receive far less charge master prices depending on the payer type, which both inadequate and inefficiencies are among the key stakeholders. So part two of the question was to assume that payers of 46% Medicare, 34% commercial managed care, 16% Medicaid, and 4% self-pay. And then we were to calculate the payments for each of these two procedures. So here are the calculations associated with the MRI of the knee. And as you can see, on average, these average expenses totaled up to $717.46. Next, we're going to look at the joint replacement. Here we are looking at the joint replacement and one with the 46 for Medicare, 34 for commercial, 16 for Medicaid, and 4 for self-pay. On average, the average joint replacement would be $18,658.
Now we will discuss how the revenue cycle benefits healthcare and why good performance is important to providers. RCM can significantly benefit healthcare practices in several ways. One way would be increased revenue. Healthcare practices can maximize the revenue that they collect from services provided. Next, cost savings. Efficient RCM processes reduce the administrative burden on the healthcare staff. Scalability. A robust RCM system is scalable and can adapt to the changing needs of the practice. Next, improve compliance. RCM systems are designed to stay up to date with regulatory changes. And lastly, better patient care. RCM allows healthcare providers to focus on what matters most, delivering exceptional patient care. Next, the performance and revenue cycle affects operations management decisions in the following ways. Financial stability and growth. RCM generates income and ensures financial stability. Cash flow management. Efficient RCM helps manage cash flow. Business performance evaluation. RCM informs decisions about business performance. And lastly, revenue growth. Optimizing revenue cycle operations can increase revenue growth.